Okay. Good evening, everyone. Before I start on tonight's lecture, which is on the renal disease, there's a couple of points that I just want to bring out. The first of those is that we're swapping the lecture topics for the next 2 weeks. So that next week we were scheduled to talk about type 1 diabetes and the following type 2. Shivani's going to be delivering our type 2 diabetes lecture, and she's going to be delivering that next week, hopefully, and not delivering something else, right? And then I'm going to be doing the lecture the following week. And that's primarily because some of you may know that Shivani's very advanced in her pregnancy, and I want to make sure that she is able to deliver the lecture to you for type 2 diabetes, and there's more chance of that next week than the following one. So we've had to swap, and I hope you'll appreciate that there's a very good reason for that. We'll still call them lecture 12 and lecture 11. So lecture 12 will be next week and lecture 11 the following week, and we'll just keep those numbers the same because that matches up with the content in Canvas. So you'll be able to see the same numbers there if you're going back through things. So just be aware that next week we're recording type 2 diabetes and the following week type 1 diabetes. And the second thing that I wanted to mention, I've got a moth flying around in front of my eyes, so if I go like that, that's why. The second thing, I've looked through the survey responses, and I probably will digest them a bit further over the next few days, but thanks very much to all of you who responded to that and filled in suggestions, and it's really, really helpful and great to look through. I guess it's hard to summarize things overall, but in terms of lectures, I guess people pointed out the pros and cons. So on the one hand, having lectures and seeing people's faces is reassuring, but on the other hand, it's hard to make it at that exact time, which doesn't suit everybody. And I don't think that there would be a time that would suit everybody. No matter when we did it, it would suit some and not others. So it's really hard in that respect. Oh, about 4 or 5 people said, could you please put the PowerPoint presentation on Canvas? And I think it was very important to bring that out because I do every week. I usually put it up 2 or 3 days before, but just in the last couple, I've been a little bit later getting the lecture organized, but it's always up. If you look down on Canvas on the homepage and scroll down till you get to lecture PowerPoints, and there they all are. So for those of you who hadn't noticed that, sorry that wasn't made clear, but they're all there and you should be able to see them and download the PowerPoints in advance of the lecture. As I said at the beginning, it was about a week in advance, but now it's sort of getting to sort of like 2 or 3 days in advance. But so far, always in advance of the lecture, they're up and they remain up through the rest of the course. Those of you who've been able to attend the tutorials on Saturday mornings with Shivani have overwhelmingly given positive feedback about those. So it's great to hear that those are working, and and that people can view the recordings of them if they want to, and that they also appreciate the summaries that Shivani sends to Piazza early in the week following the weekend tutorial as well. One suggestion which was very helpful was that perhaps we could have an ability to ask questions by email, which Shivani could then cover in the tutorial. And then, of course, that's for people who can't actually make it on Saturday morning, but could still listen to the answer to that question. So yes, we'll try that. If you have any questions and that you want covered in the tutorial, but you aren't able to attend, could you please email to me, c.bacon@auckland.ac.nz, and I will forward that on to Shivani. I'm not guaranteeing she'll be able to cover all of the questions if there are lots, but she'll look through them anyway and pick out some of the key ones which she'll cover in the tutorial. Shivani, I saw you turn your mute off. Did you want to say something?
Yes, I'm sorry to interrupt, but just a quick point, because I had made the suggestion during the tutorials as well that they can use the folder on Piazza that says tutorial summaries to ask their questions there, and so that'll make it easier for me as well and for everybody else to see what questions will be discussed in the upcoming tutorial.
Fantastic. Please do that, because as those of you who've emailed me know, I'm a little bit behind, quite a lot behind in my emails, and I, can continuously have difficulties trying to keep up to date with them. So if you've emailed me, I will answer, but I know it is a little bit slower. And so using the other systems like Piazza that Shivani set up is by far preferable. Thank you. Thanks, Shivani.
Thank you.
Great. So I'll put this lecture on. Great. So tonight's lecture is, as I mentioned before, on renal disease. 5 minutes starting. In today's lecture, I'm going to be starting off by reviewing the gross anatomy and microscopic anatomy of the kidney and microscopic nephrons, the functioning units within the kidney. So I'll be talking about Bowman's capsule, glomerulus, and nephron, and how the kidneys work, how they operate to maintain our fluid and iron balance, and keep homeostatic or keep constant levels of the nutrients that we need within our blood supply, and of course within our surrounding body fluids around our circulation. I'll talk about in particular the role in maintaining osmolality, or the concentration of fluids, and blood pressure, local blood pressure. And I'll be reminding you that the control of blood pressure is actually something that happens systemically. The kidneys are not primarily involved in maintaining blood pressure, but they are able to respond to it. So I'll be talking about local renal control and regulation with respect to concentration of body fluids and blood pressure. I've got here edema and development of renal disease. I've actually cut that out, and I should have deleted that because we covered that in cardiovascular in our long lecture, which makes this lecture a little shorter. And of course it made the cardiovascular lecture quite long, but at least this one should be a bit shorter. And an overview of the portfolio assignment case studies as usual. So just as a reminder, this is the macroscopic structure of the kidney, and the outside of the kidney is this region which we call the renal cortex. This is the tissue, the flesh of the kidney, and this is where the nephrons start, though some of them extend right down deep to within the kidney. The middle part of the kidney is called the medulla, and we have these just remember, okay, that's right, lobes. They have the lobes separated by septums in the middle, and so this middle region with the lobes is called the medulla. And the filtrate from the kidneys drains into this region of the kidney, which is known as the renal hind, and then finally down into the ureters, which, as we know, descend down to the bladder. There's around the functioning unit of a kidney is a nephron, and there's around 1 million nephrons in each kidney. And I'm going to be showing you on the next slide a little picture of those. There's 2 types of nephrons. Some nephrons, the bottom part of their functioning unit doesn't extend beyond the cortex, whereas others, or just the top part of the cortex, whereas others of them extend deep down into the cortex, almost as far as the medulla. So there's 2 types of nephrons. We'll think of them as short ones or long ones. Won't give them their complex names at this point. The main purpose of the kidney is to regulate the volume and composition of blood. And in doing that, because fluid and small ions, small molecules, can move freely between the blood and the surrounding body fluids, they also maintain the concentration and of our body fluids as well. So that's their main role. Now they do that by filtering all blood that comes through them, by pushing out the fluid part of it, and then resorbing back into the circulation, back into the blood supply, what we need in terms of fluid and ions and other particles. And the remaining substances that have been filtered out through the kidney that aren't resorbed are passed out of the body in the urine. And that's how the kidney functions. So it's important to remember that if for any reason the nephron isn't, this is the yellow part here, isn't functioning properly, then in that situation, we won't be able to regulate fluids or sodium or chlorine in the body, chloride ions in the body. So no matter, even if renin's still working, we're producing renin, we're producing aldosterone, we've still got the hormonal control going on, but they can't function because the way that they function is through this function of the kidney. And if the kidney's not able to filter the blood, then it also can't regulate the homeostatic concentration of these ions. So this diagram summarizes the blood supply to the kidneys. The renal arteries arise directly from the abdominal aorta. So they're quite close to the left ventricle of the heart, and therefore the pressure in them is very high. They enter this part of the blood circulation, which is a twisted network of capillaries known as the glomerulus. They enter that through the afferent, this is a little difficult to understand this diagram because of the arrows and the way it's drawn. I've had this problem before. They enter via the afferent arteriole, which is in this diagram is shown in the bottom section, and then they exit via the efferent arterioles, not via veins. Like most capillaries, when they drain from the capillaries, it goes into veins. But in the case of the kidney, it doesn't. It comes out as another type of artery, and those arteries supply the rest of the kidney. They some of them circulate around the tubules, and they collect the resorbed particles that are coming from those tubules. Others of them supply the kidney tissue itself so that the kidney is able to function, or the kidney cells are able to function correctly. And some of them descend, some of the capillaries descend right down into the base of the kidney, and they form a network known as the vasa recta. They have very tight hairpin turns between these capillaries, and because of that, the blood flow is reduced in speed, and that's an area where there can often be thrombuses forming, embolisms, so they can be an area where we can get problems. Anything else I wanted to say on this slide? No. This diagram shows multi-level, the kidney on multiple levels. This is our gross anatomy of the kidney, and we see a little square there, which is indicating this part here, the glomerulus, surrounded by Bowman's capsule. And the Bowman's capsule is the structure that leads into the tubules in the kidney. We have the proximal convoluted tubule, then this deep descending loop of Henle, which rises up again and becomes the distal convoluted tubule, which drains into this structure here known as the collecting duct. A lot of this lecture we're going to be focusing on this very important structure here, the glomerulus. So we see how capillaries in here, remember the lower one is the afferent arteriole, which is leading into the glomerulus, and the efferent arteriole, which is leading out. And we're going to be covering them again in some of the function later on. So just keep that structure in your mind. Surrounding this network or lattice of capillaries is the Bowman's capsule. Notice that there's a tube leading out at the base of the Bowman's capsule, and that leads into the rest of the kidney tubules. So the fluid that's filtered out from the capillaries enters this tube or exit at the base of the Bowman's capsule and goes into the tubules, and some of it will become urine. I had some numbers here just to give you a feel for how much we are actually filtering in our kidneys every day. So I think, yes, so in the first slide, I was going to mention around about 180 litres of blood each day are filtered through the kidneys. So there's 180 litres of filtrate entering the Bowman's capsule every day, and some of that, or the vast majority of that, only 1 to 2% of that ends up being excreted in the urine. So the vast majority of that is being resorbed back into the circulation. So it's a huge task that these nephrons have. There's around about 1 million of them in each kidney, so there's thousands and thousands of these functioning units, and collectively they do a huge job in terms of filtering and then resorbing a great amount of our blood. So yes, so all blood is filtered every 5 minutes. So if we could take a section of blood or blood fluid, it would be filtered every 5 minutes on average through the kidneys. So that's how much, or the proportion of the volume of our blood that's being filtered. And the other thing to note about kidneys, sorry about that, the other thing to note about the kidneys is, although they only constitute about 0.5% of our body weight, at rest they take 1/5 to 1/4 of our cardiac output. So that's obviously both of them added together. So a huge amount of blood goes through the kidneys at rest in proportion to our whole cardiac output, and that's why they're able to do such a fantastic job of filtering our blood. Okay, so I think I said everything there. I just put this slide up because I just want to also introduce or remind you, hopefully, about some of the main cells that are in the glomerulus, because I will be mentioning them again when we come into talk about control of blood fluid concentration and control of blood pressure and blood volume. So the first of these cells are the macular denser cells. These are at the base of the structure here. This structure here is actually the intersection between the loop of Henle and the distal proximal tubule. So perhaps it would be easier to just go back one just to show you what I'm talking about there. So I go back to the previous slide. So we have the loop of Henle, which descends. It's kind of a bit of an unclear diagram. There's our descending loop of Henle and our ascending loop of Henle, which is here, and right at this junction between the ascending loop of Henle and the where it becomes the distal proximal tubule, which leads into the ureters, we have on the inside lining of those, close to the efferent and afferent arterioles, we have these cells called the macular denser cells. So go back again, and so here they are represented here. The macular denser cells, they're responsible for sensing the concentration of our fluids, the osmolarity, and able to adjust various things for that, which I'll talk about later. The juxtaglomerular cells, right next door to them, are located on the outside of the afferent and efferent arterioles, of the afferent arteriole only, are able to, they're the ones that produce and release renin, and they release it in response to signals from the macula densa about the concentration of sodium, and indirectly blood pressure as well, because that affects renal flow and also affects how much sodium enters the macula densa. And they also release renin in response to stretch receptors, which are in the arterioles themselves, the afferent and efferent arterioles, going in and coming out of the glomerulus. The mesangial cells are located in between the glomerular capillaries within the Bowman's capsule, and they have a number of roles in keeping the filter clean, and they work like a sponge, take up various metabolites that have perhaps become trapped within the Bowman's capsule, and break it down so that it's not clogging up the filtration process. They also release other factors that maintain epithelial cells, so they kind of have a role in just maintaining that environment within the Bowman's capsule. And they also have some contractile properties as well. These cells, there's a cell nucleus that surround the capillaries, are known as podocytes. And podocytes have processes which encircle and surround the capillaries, which we call pedicels. And they're important too. They provide an extra layer for trapping particles, and I'll be referring to them as well. The pedicels are the processes that come off these cells called podocytes. And they act like fingers around the capillaries so that they're enclosing it and creating extra barrier to trap particles that are being squeezed out of the capillaries. In renal disease, the glomerulus is the most common structure that's affected, and that's why we'll be talking about that most within this lecture. And I'll talk about some of the problems that happen when we have inflammation of the structure called glomerulonephritis. And to a small degree, both of your case studies are within this topic. Both Mr. Johnson, I think I got the name right, Mr. Johnson and Jackie have a degree of glomerulonephritis. So we will be talking about that in general terms and what can cause it and what happens in glomerulonephritis and how that affects kidney function. So I've talked about this filter that's going on between the capillary lumen. So these are the glomerular capillaries, and this is the inside of the Bowman's capsule, the white section here. But for particles to get from the capillary to the Bowman's capsule, they have to pass through three main layers. They need to pass through the capillary endothelium, which has got small pores that allow particles to get out. They also need to pass through this section of or matrix in the middle called the basement lamina. And then they also need to pass through these foot processes, which are called the pedicels. They're I say foot processes, they're more like finger-like processes, which encircle the capillaries that I mentioned before. So if we see them microscopically, they create an additional barrier for particles to get out. Just to give you a feel for the size, particles that are less than 6 nanometers. Now, a nanometer is a millionth of a millimeter or 1,000th of a micrometer. So very small. So between smaller than 6 nanometers, particles easily get through the layer. So that would include, of course, all water molecules, ions, and small molecules are pushed out into the Bowman's capsule and into the filtrate. Particles above 8 nanometers don't get out very easily. They stay in the circulation. If they're sort of in that area between 6 and 8 nanometers in size, they may get out, but the charge becomes important too, because each of these layers have negatively charged structures on their proteins, which stop negatively charged particles from escaping. And so, for example, albumin is a long protein, and it tends to be about 15 nanometers long, so that's longer than 8 that I said was the maximum. But it's if we look at it in cross section, it's like a rod. It's only about 3.8 or 4 nanometers in width. So technically, if it was kind of went on its end, it could get out, but it tends not to get out of the blood supply because it's negatively charged. So that stops it from escaping most of the time. Blood cells, for example, red blood cells, are 6 to 8 micrometers. So they're 1,000 times the size of anything that is able to get out of the out of our circulation into the Bowman's capsule. So it's only an injury or damage where that can happen. So under normal circumstances, no blood cells are anywhere near being filtered out of the kidney because the pores are just way too small. And I will mention this later, but the other thing to mention is in the early stages of glomerular nephritis or glomerular inflammation, these pores tend to open up, and that lets larger molecules and perhaps even small cells like red blood cells, it lets some of those escape. And that's where we might get hematuria or albumin within our urine. But in more advanced stages of glomerulonephritis, the pedicels particularly swell up, and that tends to block off that nephron and stop any particles from being filtered out at all. Now, that means then an advanced glomerular inflammation, that nephron's no longer able to function. So it's not working in terms of maintaining homeostatic control of our fluid balance or blood volume. And if that happens en masse to lots of nephrons through the kidney, then the kidneys aren't able to function at all. Regardless of our hormonal systems that we have in place, they're not going to operate, because they all operate through this filter system by being able to selectively decide which ions are going to be resorbed back into the bloodstream and which ones are going to be excreted into the urine. So that can't happen in advanced inflammation because there's no filtration going on. When was I? Oh no, the next slide. I was going to say when I was mentioning about GFR, but that's the next slide. So very much like the capillaries, which I covered in last week's cardiovascular lecture, what determines the amount of filtrate that enters the Bowman's capsule depends on different pressures. Now we have pressures pushing the blood fluid out into the Bowman's capsule, and we also have some pressures pushing or pulling it back in again. And under normal circumstances, because there's a very high pressure in these capillaries, because remember they're just coming straight from the heart and they're very small and have a large surface area, but the pressure pushing out is around about 55 millimeters of mercury. We also have some backwards pressure, so we have some pressure from the surrounding Bowman's capsule fluid pushing back in again, but that's much smaller, only about 15. And just like in the capillaries, we have what we refer to, and I know I used this term last week, so I'll explain it a bit more carefully. We have colloidal osmotic pressure. That's the osmotic pressure that's caused by the large proteins, because they have some charge on them as well, that tends to pull fluid back into the capillaries. So just like in our normal systemic capillaries, our glomerular capillaries work in the same way. So they have pushing pressure and pulling pressure, and under normal circumstances, the pushing pressure is much higher, so fluid is pushed out of the glomerulus into the Bowman's capsules. Clinically, we can measure how much our kidneys are filtering by a measurement that we call estimated glomerular filtration rate, eGFR. I always keep saying eGRF, but eGFR. Now, we calculate that through measurements of a substance called creatinine, either blood measurements or urine clearance of the substance creatinine. And the reason that we use creatinine is a metabolite that's produced at a reasonably consistent rate, which we can predict from a person's age and perhaps their body weight and lean muscle mass and factors like that, depending on the prediction equation. So we can pretty much judge based on those factors how much creatinine somebody will be producing each day. And just about all the creatinine that's in the bloodstream gets filtered out. It's a very small molecule, almost 100%, and none of it almost gets resorbed again, and none of it gets secreted within the kidney tubules. So what we know is whatever creatinine ends up in the urine is all the creatinine that was filtered. And so we can use the concentration of that to figure out the total amount of filtrate that went through the kidneys. Similarly, we can use the inverse of that. Any that's left in the blood, the more that's in the blood, we know the less glomerular filtration rate we have. So some of the equations use serum, like a Cockcroft-Gold equation, use serum levels of creatinine in a backwards way to estimate the amount of glomerular filtration that has taken place. When we estimate it that way, we talk about creatinine clearance. But it's all getting at the same principle, which is the amount of filtration that's going on in the kidneys as a whole, both kidneys and all the 2 million odd nephrons that are functioning within those kidneys. So in general, we can think of osmolarity as the pulling pressure for movement, bringing fluid and fluid in particular back from, once we filtered it out, it's being brought back into the surrounding tissue, and then that in turn is going back into the surrounding capillaries of the kidney. It's not just proteins, of course, that are causing this total osmotic pressure. It's all the other substances within the filtrate as well, all the ions and so on. And each of the different parts of the tubule has a specific or different role in what's being resorbed. So our fluid and ions and very small proteins are pushed into the filtrate and they enter the proximal convoluted tubule. In the proximal convoluted tubule, the vast majority of these ions are resorbed again. So right at the beginning is where the process is taking place. So that includes most of the calcium, most of the chloride ions, most of the potassium, most of the glucose and amino acids. All of these are resorbed in this proximal convoluted tubule. Also our nutrients that we need for energy, like amino acids and fatty acids. And most water is also resorbed in this section as well. It's the loop of Henle where we're able to concentrate the urine, because there's such a high volume of fluid that has been filtered out of the kidney. We need this long loop of Henle to give time to get most of that fluid back again. And it works in quite an ingenious way. Essentially, the ascending limb of the loop of Henle actively pumps out sodium and chloride ions into the surrounding tissue, and that maintains a really high concentration, which is higher deeper into the kidney, because that's where it's not being diluted by the continual influx of the filtrate that's coming from the Bowman's capsule. So deep in the loop of Henle in humans, we have a surrounding concentration of about 900 milliosmoles. Some animals, like desert rats, are able to concentrate their urine to an even larger degree, and they may have a concentration of up to 2000 milliosmoles in the bases of their loops of Henle. But in humans, around about this 900, so that allows us to concentrate the urine reasonably well. The distal convoluted tubule is where a lot of the hormonally controlled action takes place to fine-tune our osmolarity. So our regulated absorption of sodium and chloride ions occurs in the distal convoluted tubule through various types of channels there. Oh, that's right. It's one exception is there is also there's also the drug furosemide works in the ascending loop of Henle. That works through a co-transporter, a sodium potassium chloride co-transporter, which is in the ascending loop of Henle. So that's a bit of exception, but most of our diuretic drugs work in this distal convoluted tubule area. So thiazide diuretics, for example, work in this region in the distal convoluted tubule. I'll stop swinging my mouse around because it keeps bringing up that black. Sorry about that. Okay, anything else to mention? And it's also where aldosterone has its action in the distal convoluted tubule. Aldosterone also regulates the resorption of sodium. So when aldosterone levels are high, we resorb more sodium. And I'm going to be explaining about this mechanism later on, but with that sodium comes an increased resorption of water, mainly in the collecting duct, and that's through the action of another hormone called ADH. So both those two hormones together, aldosterone and ADH, ultimately regulate our blood volume and the volume of our surrounding interstitial fluid, and also its concentration. And so it's quite an ingenious mechanism, which I'll be talking about for most of the rest of the lecture. So I'm starting with ADH. I guess this is our basic mechanism for controlling the concentration of our body fluids. And a very similar mechanism is in all vertebrates. It's a very basic mechanism that evolved quite early on. So it's common to lots and lots of, higher animals within the animal kingdom, this exact same mechanism. The concentration of our blood is sensed, there's different places in the body, but in this diagram, it's sensed by these structures here called the central chemoreceptors. And they're drawn in the hypothalamus. My understanding is they're actually in the medulla of the brain, but they probably then send a signal to the hypothalamus, which is perhaps what this diagram showing. So they're sensed in the medulla, they send a message to the hypothalamus, and that results in the release of this hormone, ADH, antidiuretic hormone, from the posterior pituitary. ADH has an effect on various organs. In the kidney, that's what we're talking about in this lecture, its primary effect is to increase the amount of water channels in the collecting duct, which increases the amount of water resorption in the final part of the kidney tubules before it's excreted in the urine. So we could think of it as the fine-tuning of either concentrating the urine by resorbing more water, so the blood becomes less concentrated, but the urine becomes more concentrated, or the opposite. Reducing levels of ADH means that we are able to excrete less concentrated urine, so a greater volume of urine, and decrease consequently the volume of blood, or increase the concentration of the blood. So it's a bit confusing with increase and decrease, but essentially let's think of it as ADH causes us to retain more fluid or more water if we need it because we're dehydrated or because we've lost a lot of blood. And it has some other effects too. So there is a condition where people don't produce this hormone, ADH. Hopefully you can remember what that is. So if we have a real lecture, I could ask, but hopefully we recall that that's called diabetes insipidus. And it's called diabetes, but it has absolutely nothing to do with normal diabetes, either type 1 or type 2. It's a completely different mechanism, but the only thing that is clinically similar about it is we produce a lot of urine, just like we do with diabetes, but for a completely different reason. And that's what happens when we aren't able to produce ADH. And the second hormone that's very important in regulating our blood volume and blood concentration is this hormone called aldosterone. Now, we're all familiar with the renin-angiotensin-aldosterone system, and we're familiar with that because there's a lot of patients who are on angiotensin converting enzyme inhibitors or ACE inhibitors. So we get to know that system, but it's important to remember that that's not the primary system for maintaining blood volume and blood pressure. Most of that is maintained directly through this hormone aldosterone. And the way that that works is when our central chemoreceptors or our peripheral chemoreceptors, which are in the aortic arch and in our carotid arteries, or our baroreceptors, which are located also in the carotid arteries or the aortic arch. So when any of those receptors indicate that we have low blood volume or an increasing concentration of sodium, they send a message directly through the anterior pituitary, which releases an important hormone called CRH, corticotrophin releasing hormone. Sorry, that's released from the hypothalamus, and that causes, the anterior pituitary to release ACTH, and that's the hypothalamic corticoaxis, and the ACTH causes the release of various steroid hormones from the adrenal cortex, but in particular in this case, as well as cortisol, it's also increasing the release of aldosterone. So the aldosterone is also released from the adrenal cortex, just like cortisol. And aldosterone has the effect that we mentioned before of helping the distal convoluted tubules to retain extra sodium. And because extra sodium is being resorbed back into the bloodstream, that's drawing water with it and re-increasing or restoring our blood volume and therefore our blood pressure. So that's the direct system. Renins and angiotensin are only involved in very extreme cases, and I'll be mentioning that shortly, but they're only involved when there's been a massive loss of, quite a large loss of blood volume or extreme dehydration. Most of the time, just for day-to-day alteration in blood pressure or blood volume, this direct system is what the body uses for regulating blood pressure and blood volume. But because this is a renal lecture, I'm going to bring up the renin-angiotensin system because it is also involved. And the other thing that happens is in some chronic diseases for different reasons, for example, because of insulin resistance or problems with endothelia and various signaling that occurs, for various reasons, renin concentration pathologically rises. And so that's what causes pathological hypertension as well, is that increasing renin is the primary reason for that. So that's why renin becomes important. But in normal circumstances, renin's not involved in increasing blood pressure, but it does happen in these chronic conditions. And that's why we're covering it particularly in this lecture. This is a simplified diagram of how the renin-angiotensin system works. So renin, as I mentioned before, is released from those cells, the juxtaglomerular cells within the kidney, and they cause angiotensin 1, which is produced in the liver. It causes it to be converted to a second form of angiotensin called angiotensin 2, and that happens in the lungs, primarily in the lungs. So renin causes an increased production of angiotensin, and as well as being a potent vasoconstrictor, which helps to maintain our blood pressure, it also causes the release of renin and, the release of aldosterone. And aldosterone helps us to retain sodium. So in the longer term, that's also going to restore blood pressure and also no, I don't know what I was going to say. So that also helps us to maintain blood volume. And of course, we also have ADH involved, which is bringing water with it, which is increasing our blood volume because there's an increased concentration of sodium that was from the action of the aldosterone. This diagram's showing what happens when blood pressure falls. Our mechanisms for reducing blood pressure when it's elevated are not quite as good as our mechanisms for adjusting for falls in blood pressure. Of course, it's very important to maintain a degree of blood pressure because our important organs are quite high in our body. So we have to pump the blood, for example, from our heart up to our brain. And so if our blood pressure falls, we become unconscious very quickly. So we need to maintain blood pressure, and we have lots of mechanisms in place to retain that through cardiovascular mechanisms that we covered last week to these mechanisms here through the renal function. So in addition to these central mechanisms that control blood pressure, we also have local control of blood pressure in each nephron, within each glomerulus within the kidney. And this diagram's a little messy. I've simplified it a bit by getting rid of some of the unnecessary information in it, but it's still a little bit hard to digest. But I'm just going to sort of take it step by step. So when we have a decrease in blood pressure, a couple of things happen. The first of those things is usually associated with an increased concentration of sodium. So for example, if we're dehydrated, we have a lowered blood pressure because we have a lower volume of blood, but we also have an increased concentration of sodium and chlorine ions. And these are sensed by the macular denser cells, which send signals to the juxtaglomerular cells to release renin. Also, as well as that, we also have a decrease in the stretch on the afferent arterioles leading into the glomerulus, and they also send a message to the juxtaglomerular cells to increase renin production. So both those two things are going on. There's a third mechanism too, in that when our renal blood flow drops, that's also indirectly causes less sodium to enter the macular denser cells. And so indirectly that also causes the juxtaglomerular cells to result in an increased production of renin. So all these factors, we have a drop in arterial pressure, all these factors cause renin release. Renin causes increased production of angiotensin II. Angiotensin II tends to cause vasoconstriction. And it would restrict both the efferent and afferent arterioles. But what also happens is that because of the juxtaglomerular cells also release prostaglandins and other chemicals like nitrous oxide into the afferent area, and that tends to cause or maintain vasodilation of the afferent arterioles in this situation. So we have the overall effect of vasoconstriction caused by angiotensin II, but it preferentially restricts the efferent arteriole because the afferent arterioles are being kept open by the prostaglandins and by the nitrous oxide. And what therefore happens is we end up getting more blood entering the glomerulus. Wish wouldn't do that. More blood entering the glomerulus and less blood leaving because the efferent arterioles have constricted, and that maintains the pressure inside the glomerular capillaries because the blood's being stopped from leaving even though there's still a high pressure or high volume of blood entering each glomerulus. Now this can have this has local control implications. So if there's particular nephrons that for some reason are not getting a good blood supply, this local mechanism will make sure that there's sufficient pressure to allow filtration to take place within that nephron. So there's local regulation within each individual nephron within the kidney, but it also works on a whole body level. If we have a drop in blood pressure, it's an additional mechanism to help restore that blood pressure and to help maintain kidney function. Of course, we need to maintain kidney function because one of its jobs is to maintain blood pressure through the action of aldosterone in resorbing the sodium and through the action of ADH in resorbing the water. So if our nephrons weren't working, we wouldn't be able to restore blood pressure. So that's why it's really important that we maintain adequate pressure within the glomerulus so that filtration can take place. So in the past, I don't know why this is, I've not actually seen it, but I understand in the past a number of students have indicated that renin is what we use to maintain blood pressure. So I'm just going to reiterate that it isn't. Under normal circumstances, blood pressure is maintained through a number of mechanisms, but primarily through cardiovascular and neural mechanisms. This diagram summarizes the integrated control of blood volume and blood pressure. So a drop in blood pressure, for example, is picked up by the baroreceptors and also picked up if it's affecting the concentration of blood fluids. It's also picked up by the chemoreceptors, which are in the brain and also in the periphery, in the same place roughly where the baroreceptors are, so in the carotid arteries and the aortic arch. So just to reiterate that, there's chemoreceptors in the brain and also in the carotid arteries and in the aorta leading from the heart, and there's also baroreceptors or pressure receptors in the carotid arteries in the heart. So all of those are responding to changes in blood osmolarity and blood pressure. If there's a drop in blood pressure, various things happen. The quickest thing that happens is that we have an automatic neural response, sympathetic nervous response to the heart, which increases stroke volume and heart rate, which we covered in the cardiovascular lecture last week. But we also have a direct release of the hormone aldosterone that I mentioned 2 slides ago. And so that's over time is also helping to restore blood volume back to its normal level through the action of the sodium. And then we also have if in extreme drops in blood pressure, we also have this additional action of a release of renin, which is increasing aldosterone through angiotensin. And angiotensin itself is also causing systemic vasoconstriction, which is maintaining the blood pressure through our circulatory system, making sure that things function until we can retain or bring back more fluid and more sodium through our kidneys, which takes a little bit longer. So all these mechanisms are working together to maintain blood pressure and blood volume. And we have lots of mechanisms to do that because it's really important for us, our survival, to be able to maintain blood pressure. Now, I'm just, as usual, I just want to finish by coming on to our case studies. You have a choice, just like the cardiovascular system, you have a choice in the renal system of the adult case, who is Mr. Johnson, who's 90 years old and has an acute kidney injury, or our pediatric case. And we have Jackie, who's aged 5 years and has a condition known as pyelonephritis, secondary to a urinary tract infection. Pardon me for just getting slightly mental blank there for a second. Now, as I mentioned before, with both cases, they have a degree of glomerulonephritis, a degree of inflammation within the kidneys, and that's affecting function. It hasn't reached the extreme stage that I mentioned before. So it hasn't reached the stage in either of these 2 patients where a significant number of nephrons are not functioning at all because the glomerulus is closed off and not filtering. But it's in that initial stages of inflammation, probably, or a lot of the nephrons are for both these cases. So think about the impact of that on the renal function for both these 2 cases. And for Mr. Johnson, consider in particular how the effect, the possible N7, I won't give away any answers here. No, I'm not really. Think about how that potential effect of toxicity from the drugs that he was taking, combined with the aging process and the effect that that has on the kidney and dehydration. Think about how all those factors together are influencing his renal function. And I'm not talking specifically about any questions in particular at the moment, but just in general what's going on with this case, because it's a very common scenario in older people for this to a lesser or greater degree to occur. And with Jackie, we're more thinking about how the infection has got into her kidneys in the first place, which we can think about in terms of the anatomy and also in terms of the structure of the bacteria which are infecting her kidney. So that's the main things to think about in these cases. I think it's important also to remember that in both cases, drugs can be involved, and remember that all drugs are metabolized to some extent, and in the final process, all of these metabolites from drugs need to be excreted through the kidneys. So some of them are broken down substantially in the liver first, but all the metabolites end up in the kidneys. And if some of these foreign metabolites get stuck within our filter system, within the glomerulus, think about what can happen if a foreign substance is stuck somewhere in the body. What's the response of our immune system to that? And where is that happening within the kidneys? And how could that be exacerbating the problem? So think about the importance of fluid and hydration in both these cases for our kidneys to function properly, making sure that no filtrates are getting caught within those 3 layers within the glomerulus, and it's being that the fluid is pushing things through. So that can also be another factor involved with some of these cases. Just to remind you, and I know I did mention this before, but just to remind you, this is a diagram showing you what can happen with advanced glomerulonephritis. I don't think this is especially relevant to either of these cases because I don't think either of them have got to this advanced stage, but I'll just mention it anyway because this is where the slide is. So remember, in advanced stages, particularly the podocytes with their finger-like processes around the capillaries, they swell up, and so particles are not able to filter out into Bowman's capsule. And also mesangial cells increase in size. So these are the changes with with more chronic or more advanced glomerulonephritis. In the initial stages, though, the pores open up and let out much larger molecules and small cells than would have been let out initially. So that can be why albumin and perhaps even in extreme cases, blood cells can be pushed out of the glomerulus into the renal tubules and then out into the urine. So specifically, the questions, and this is what you're all wanting to know. So with this year, the questions that are coming up in your portfolio, so we have 3 questions that you can choose for Mr. Johnson. And the first one is the reasons for his low glomerular filtration rate. So this is thinking about his case as a whole, what's going on here. There's probably, I mean, you might have the odd citation here, but it's more thinking about the function and explaining why his GFR has dropped. Think about what's likely to be the main cause of the inflammation that's occurring, but also the contributing factors of dehydration and aging that are occurring in that situation as well. Question 2 is the reason for withholding beta blockers in this situation. So think about what's likely to be happening to Mr. Johnson's blood pressure in this situation and what beta blockers do and how they might make things worse. So once again, probably you're not going to need a lot of citations for that. Again, it's understanding how the process works. And then the third question is about the use of, yes, I can't remember exactly how the question's phrased, but it's about effective and safe intervention. So think about the clinical goals and targets for treating or managing Mr. Johnson. What's the likely effect of those interventions? And are there any relevant safety recommendations that need to be taken into account? So that's the one where you might be doing a bit of research as well to figure out those, unless you work as a renal nurse and already have a lot of knowledge, in which case it'll be easier for you. You can probably find things to support what you know is the clinical answer for question 3. Jackie, who has pyelonephritis, the 3 questions, I guess there are, we often ask questions, but there's not one this year about the underlying cause of her urinary tract infection in the first place, which is because of a anatomical abnormality in this situation, which can increase the risk of someone having vasocortical reflux, which is a movement of urine in the opposite direction back into the ureters from the bladder, and that can be a risk for urinary tract infections and ureteral infections, which can even rise up to the kidney. But we haven't got a question on that this year. So the first question is about how the infection has got to her kidneys in the first place, and that's got a lot to do with the structure of the most common bacteria responsible for this infection, which is E. coli. And the second question is about how come Jackie's got proteinuria and hematuria. So again, hopefully you can think about some of the processes that are going on that I've described in this lecture and explain why that's happening, and hopefully you can find some support for that as well, not just from the lecture, but you can do some reading and confirm that this can happen. And in the third question, so sometimes we've asked about clavulanic acid, but no, this year a question is on the antibiotic itself, on gentamicin. So again, a little bit of research for the intervention, finding out how this particular antibiotic works specifically and why it's being delivered intravenously. And so I've got a little picture of E. coli. It's not an electron micrograph. It's a what's it called, computer generation of what it looks like. But hopefully this might give you some clues as to what aspects of this particular bacteria structure enables it to kind of go backwards against the flow of urine and maybe get from the bladder up to our kidneys. And that's the end of today's lecture. Oh, no, that's right. There were two things that have come out of the feedback. The first is one or two people said that rather than my lectures, they preferred looking at animations that explain things more coherently and without any ums and ahs and everything. Great. Sorry, I can't get it perfect. But we do provide you with lots of those YouTube links in Canvas, and hopefully you've gone through some of those resources and seen them all. And there's also some that I think are particularly fantastic about the kidney. I'm so jealous because you know, when I learned the physiology for kidney, it was all in horrible black and white sketch diagrams from textbooks which were impossible to understand. And now you can see all these wonderful resources on YouTube which explain things, you know, so clearly, and it makes so much more sense. So the kidney has a complicated structure and quite a complicated function as well. So do revise those if you're a bit rusty on your renal physiology, and watch some of these useful resources that are available on YouTube. And the other point that came up in the survey, thanks very much, is that those of you who are watching the recording, and many of you said you actually prefer watching the recording because you can, you know, pause me or slow me down and take some notes and then play me again and then kind of repeat me again. It's just horrendous from my point of view, but I can understand that. But what you're concerned about is you might be missing some of the comments and chat that's going on. So I should mention to you that I don't see the chat. I completely turn it off during the lecture because there's no way that I can read chat and plus focus on what I'm saying. And Shivani and Barbara do answer chat, but I would guess that a lot of the chat that comes up, people have posted private questions anyway, not public ones. So actually no one's able to see a lot of the chat and the questions that are being answered. And at the end of each lecture, I always ask Shivani and Barbara to say any important questions that have been raised that they can then answer. So you're really not missing out on anything if you're watching the recording. I know you might feel you're missing out on chat, but you're not, because mostly people will be asking about things that were covered in you know, in the lecture, but perhaps they didn't hear, or perhaps they asked it before it was covered. So if there's anything important, Barbara or Shivani will mention that. So please don't worry about that aspect. You're not missing anything by watching the recordings rather than watching it live. And that's the end, I think. Great. So on that note, were there any important questions, Barbara or Shivani, today?
There was a question on the changes in osmotic pressure, which Shivani answered, and a student has just asked if they need to do both, you know, both adult and child, and I've just answered, no, you do one or the other. But they were the only questions.
What was the first question, sorry, about the Shivani answer? Do you think you could read that out and the answer to it, Shivani?
A moment, I'll see if I can find it.
Maybe.
During renal compensation, the buffering process, does the colloidal pressure shift or stay the same? And Shivani answered, the bicarbonate is reabsorbed in the kidneys as part of the compensation process. Bicarbonate is not a very large ion and does not affect the colloidal pressure of the blood. Colloidal pressure is mostly generated by the large proteins such as albumin.
Right. Okay, I suppose there's a bit of terminology here which was throwing me off. I think what the question's about is actually called osmotic pressure, not colloidal pressure, because colloidal, I can't even say it, means protein. So colloidal osmotic pressure is the osmotic pressure that's caused only by the proteins. But yes, other substances also cause osmotic pressure. And so, yeah, I was getting caught up on terminology. So Shivani's answering it exactly right if the question was about osmotic pressure and bicarbonate. So this is thinking about back to acid base again from last week, right?
Yeah, I suppose that was that might have been the basis of this question.
Yeah. Not
That's
just
good.
general interest about bicarbonate, no doubt. Yeah.
But yes, that's all. I think that was the only question.
And, you know, again, reiterate, they either do the adult or the child, not both.
Yes, and same with cardiovascular, adult or child.
Child, not both.
The only one that's confusing a little is respiratory, because in respiratory you have an asthma case, which everybody does, and then you also have a choice. So for your second one, you can choose either the COPD case or the pediatric case, and she has bronchiolitis.
Yes, that's right.
Yeah, so that's the confusing one, because you have 2 cases that you have to do for respiratory. In total, at the end, you should have 10 done, 10 questions out of 100, and most of them are worth 10 points each, although one's worth 12 cardiovascular and one's worth 8. So do check that. We have had a couple of instances where people have forgotten a case or left it out, and that's kind of a lot of marks lost, because it's usually pretty easy to get the first, have a go at every single question. It's usually easy to get a few marks at least for having an attempt, but if you leave it blank, we kind of need to give you 0 for that, just like in an exam. So attempt everything, even if you're not sure of the answer, have a go, because you'll likely get some marks for it, which is better than losing all the marks, if that makes sense. Treat it like an exam. Some questions you'll find easier, some harder. Go through the easy ones, come back to some of the harder ones at the end if they're taking up too much time. Sorry, a couple of people have, I think 4 or 5 people have emailed me with their model answers and asked me to give feedback. We're not able to do that. We're not able to give you everybody feedback on their answers. I can give you some guidelines. Put them into Piazza as private posts, and then you'll get answered much more quickly than emailing me. But I will get to those people, and perhaps I'll give you some, hints about whether you're on the right track or not. But I won't be telling you this answer's right or not right, of course, just as I wouldn't be able to do if it was an exam. So have there been many questions like that on Piazza, Barbara and Shivani, of people wanting?
Well, I haven't come across.
No, there haven't been so many. I haven't seen so many.
I think just maybe very few, like a couple, I think, not too many. Not sure how many emails you received, Catherine, but yeah, not too many questions.
Yeah, I'm going to have a big burst on them again, like tonight and tomorrow, to try and get up to date. Yeah, we've just been quite busy with marking and moderating your assignment ones over the last week or 2, so that's been the big priority, to get your grades back to you. So sorry that my emails have got a little bit behind in them. Yeah, I will get to you. So Shivani will be telling you about type 2 diabetes next week, and then after that there's only 2 more lectures. So things are drawing to a close. Yeah, I agree that there's a lot of work in the portfolio part of your course. I think one person, or maybe a couple of people, said, do point out at the beginning of the course, that the portfolio is a lot of work and started early and keep up to date. I kind of think I said that in lecture 1, but maybe I didn't. Never mind, correct me if I'm wrong. So yes, that's true. And it is a good idea to, especially if you're choosing an assignment 1 on one of the cases that's in the portfolio, to use that as an opportunity to look through the material for that topic. Obviously, there's no point giving you this feedback now because that's all finished. But yes, it is important to keep up to speed with the portfolio. There's a lot of information and a lot of materials to work through. Note that the very last topic, respiratory, has 2 cases in it. So don't leave that till too late because it's a little bit more work. So you've only got one case to do for cardiovascular, one case for acid base, one for renal, one for type 1 diabetes, one for type 2 diabetes, but then all of a sudden you have 2 for this respiratory system. So you might want to kind of start that topic a little bit early because it all comes up quite quickly the last few weeks of semester rather.
The other thing I would say is in the course, there are very good readings and they're there to help you. So do use them, please, because it will help you. Some students still rely on Mr. Google and as a result, don't always get the subtleties of for the answers.
Mm-hmm.
Well, no more questions, Catherine.
Good. Okay. Well, lots of people have said that they attended some lectures live at the beginning of the course, but then they found that it was, you know, better to watch the recordings anyway. So that's why we've had a bit of a drop off probably.
Hold on. There's a question here. Is there any chance you could give more explanation about case response? It is a bit confusing. Would you like me to do that one?
Case. Oh, yes. Yes, please.
Okay. What you do,
do you want to put your face on, Barbara? So.
Oh, okay.
Or are you in an uncompromised position?
No, no, all right. I'm not in my PJs. Sorry.
Right.
Light looks a bit peculiar, but never mind.
Yeah.
What you need to do is go through Piazza and look at the case studies that have been posted. Then find a case study that you think you can discuss further. And then I'm just looking at the thingy floppy here. And then with the response,
choose another laboratory finding or?
Yes, it is. Choose one of the patient case studies, which I've suggested. Choose one clinical or laboratory finding listed in the case profile. Describe how it relates to the patient's underlying pathology. And I do mean the patient's underlying pathology, not a generic answer, but relate it specifically to the patient. It may be the same finding that's been previously described, but pathology description will be different. And identify and describe an intervention currently used to improve this finding and support this with one peer-reviewed published reference.
And just like your colleagues, you have to submit that in 2 places. Please submit it as a follow-up in Piazza so people can, you know, learn from your work because it is an interactive assignment. But of course, if you want it to be marked and graded, you also need to submit it through assignments under case response.
If you have, don't wait till the very last minute. Get onto the case, get it posted onto case response well ahead of time because there is a cutoff and nothing can be accepted after that cutoff.
Yeah, we won't be accepting late case responses. You know, you've kind of had like all the course to do them. So do prioritize to get that up to date. You know, even if you're struggling with other personal factors and so on, get that one done and then email me, not yet, but in a couple of weeks to let me know that you might require an extension for the portfolio assignment. Hopefully there won't be too many of you. Really try to finish that on time because we have quite a tight turnaround where our grades have to be back. So, you know, we have a limited thing, but there are situations that are beyond your control. And so please, you know, if you are in one of those situations, please do email and process them as normal. Okay, so we extended our chat for another 15 minutes.
Okay.
But yeah, okay.
Thanks, Catherine.
Thank you, Catherine. Bye.
Bye-bye.